my kind of takeaway is, as a primary care doctor, I think it's important that patients have basic imaging, like you said, basic x-rays done, that you've maybe already sent that patient to physical therapy. They've already tried Tylenol, they've already tried ibuprofen, and they're still noticing that they have some issues.
Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science.
I'm Dr. Russ. I am an anesthesiologist, but an interventional pain management physician. And oftentimes I've noticed that I'm getting patients in the clinic who haven't had the proper workup. So Dr. Takem, as a primary care physician, when do you think it's appropriate to send to pain management?
All right, so I guess I'm in the hot seat today.
You absolutely are in the hot seat today.
All right. So you have indicted all primary care physicians today for poor workup prior to referring patients. And yes, it's a great point you make, because sometimes we are also at the loss. Now, by and large, you tend to do basic imaging, an X-ray, lumbar X-ray, and X-ray of the knee and the type. They're easy to get before the patient comes to see the pain management specialist. And if we don't do that, yes, rightfully so, you should be upset at us. But I think that, to answer your question more specifically, when should a patient be referred to pain management? Generally, if they have failed conservative treatment. And conservative sounds like a very big word, but it's just NSAIDs or Tylenol,
ibuprofen.
Right? Ibuprofen. If you need them to get an intervention, for instance, you send them to pain management. When there is something more complex, if somebody has a lumbar stenosis or has a foraminal stenosis, is in pain and need immediate pain relief, things that are not deemed to be surgical, tend to refer them to pain management. If the patient doesn't need a knee replacement yet or a hip replacement, send them to pain management. Now, what should we do before that? Generally, our workup is limited to an X-ray. Is that wrong?
No, I think that's perfect. I think the problem is when, you get the patient who comes in with abdominal pain, or the patient who comes in with pelvic pain, and they haven't seen another specialist to kind of rule out ominous things, and they end up in the pain clinic with no kind of thorough workup, and I'm left to figure out what's going on and try to figure out and then send them to the right person so that they get ultimately the best care.
Okay, so on behalf of all primary care doctors, I apologize, but I did not know patients get referred to pain management for diagnosis outside of the musculoskeletal system. I generally refer for musculoskeletal pain. Why would anyone refer pelvic pain to pain management? Educate me.
So that's a common complaint, if you will. It could be due to fibroids. It could be due to endometriosis. It could be due to prior, surgical interventions that have then led to chronic pain. And so we still do have treatments for pelvic pain. There are specific injections or nerve blocks to help reprocess or reset how patients are thinking about pain coming from those areas. So we can absolutely help, but it's important to have an underlying diagnosis, not just because you notice that I'm having some discomfort in this area and I decided today to come to the pain management clinic because my primary care doctor gave me a referral.
Okay, so that's absolutely crazy. So what you're saying is somebody shows up in your clinic with pelvic pain without any workup for the pain management physician to sort it out.
Yeah, that happens routinely. Same thing for abdominal pain, which is a really common complaint as well too. And I'm looking through the charts and, I don't see a CT scan of their abdomen. I don't see any notes.
No ultrasound of the abdomen.
No
nothing.
Ultrasound, no notes from the GI doctor. And it becomes challenging because, they're here in my office. They're expecting something to be done today. They're expecting help. And I absolutely want to help them. But we got to make sure that they go through the proper channels. So I do also treat patients with chronic abdominal pain from chronic pancreatitis or, abdominal migraines or, again, prior laparoscopic surgery. And, sometimes there's concern for nerve entrapment, and that kind of leads to chronic pain as well, too. And we have procedures to help target them. But I say you gotta have a diagnosis and have seen all of the more important people, if you will, before you come see me.
Okay. So we're doing a sloppy job.
Sometimes, I don't want to say that. Healthcare is, a big system to sort of navigate. And a lot of times patients get lost in navigating the system and they need help. And so I totally understand that. And I'm there to help them.
But so on behalf of primary care doctors, again, I know I'm on the hot seat, but is it possible that many of these patients are bypassing their primary care doctor because they have some sort of PPO that doesn't require them to have a referral and just come to see you directly?
Sometimes that happens, but sometimes I'm looking at the plan and they absolutely need the referral. And I see the referring person.
You see the referring person.
And so that's why I think that is important. Yes, because the primary care doctor is sort of a gateway into helping you navigate things. And when patients take things into their own hands and say, I'm having this problem, I'm going to look on ChatGPT and go to this specialist to help me fix it. And I'm like, wait a minute, how did we get here? Which brings up a good point. I met a patient who, in his 30s, he comes to me and he says, hey, Dr. Russ, I've already seen, interventional radiology and had this procedure done. And I said, oh, okay, that's great. And I was like, what sort of imaging did you have done prior to this? And they said, I didn't have any imaging. I made an appointment with this doctor, got this procedure done based on my pain complaints. And I was literally befuddled. So I appreciate patients and taking, initiative and, taking charge of their own health, if you will. But there's a reason why we have certain channels in place so you can get the proper care.
Okay. So I stand again on my point that I don't think that patients saw their primary care doctor.
Okay. Touche. Touche. But my kind of takeaway is, as a primary care doctor, I think it's important that patients have basic imaging, like you said, basic x-rays done, that you've maybe already sent that patient to physical therapy. They've already tried Tylenol, they've already tried Ibuprofen, and they're still noticing that they have some issues. That is the perfect candidate to send to pain management, right? Because when I think of things in terms of, tiers, there is Tylenol, Ibuprofen. There's then going to physical therapy. And you've done all those things, you're still having issues. Now it's time for the interventional pain specialist to kind of step in. And then if we've done multiple things and we still haven't gotten any progress, if you will, then the next step is kind of surgical intervention. So that's my tier of.
Okay. So basically, you're telling us that we primary care doctors should just do our jobs.
In a sense.
Do a proper workup of the patient. Basic imaging that the patient might need, or visit to the specialist that they might need, and then send them, refer them appropriately to pain management when all these avenues have been exhausted.
Absolutely, right? We are doing our patients a disservice if we do not do those things in that order.
Okay, so we stand corrected.
We stand corrected. In general, Dr. Takem, how can patients kind of better navigate the healthcare system?
Well, I guess going back to your point, what we need to do in the typical patient being referred to pain management is getting the appropriate workup and in the form of an x-ray. Now, this all usually brings us also into a mini fight with the patients because patients want an MRI.
Absolutely.
And I think the MRI has is a legend in its own in the minds of patients because it seems like it's the end-all be-all of all diagnostic workups. And patients usually even think that the MRI will fix the pain, but when it's just a diagnostic tool. So as I say imaging, I want to clarify that most of the time is an x-ray will give us the information we need. So we do that. And of course, if somebody is complaining of pelvic pain, it will be worthwhile to do a pelvic ultrasound or an intravaginal ultrasound. Or if somebody has, chest pain, do a proper workup and send the patient to a cardiologist or a gynecologist in the case of the pelvic pain. And then when you exhaust all of this and it's been established that the patient is dealing with chronic pain, then you refer them now to pain management.
Mm-hmm.
Is that an appropriate pathway?
Absolutely. I completely agree. I think it's a structured approach to make sure that you're going to the right person at the right time, getting the right diagnosis. And so that when you actually come to interventional pain management, it's because we can actually help you. So kind of the takeaway point here is, as a primary care physician, it's important to get the basic imaging, send the patient to physical therapy, and then after those things have been kind of exhausted, if you will, the next person to see is the interventional specialist.
Excellent. Thanks for teaching us.
You're absolutely welcome, Dr. Takem. All right. So in summary, I think it's important for patients to, again, to establish care with your primary care physician, share about what's going on. That will sort of make sure you get the appropriate imaging. You're going to get established in with physical therapy, and then you'll get referred to pain management or any other specialists for an accurate diagnosis and treatment plan. I'm Dr. Tiffany Russ, and this has been another episode of the Daily Brief podcast with Dr. Takem in the hot seat here, and we will see you soon.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.